welcome everyone. This is Krista Martel with the Well Project, and I am really pleased to have you all here today for the fourth webinar in our series, our Watch series for 2016. Today, as you know, is the first part of our two-part webinar series that's going to be talking about long-term survivors. And it's good to see a lot of you online. And I know we have more joining us as we just hit 12 p.m. So today's webinar is Surviving HIV Over the Long Term, the Past, Present, and Future. And again, this is part one. So as many of you know, the Well Project is a nonprofit organization with a mission to change the course of the HIV/AIDS pandemic through a unique and comprehensive focus on women and girls. We work to leverage technology to improve health outcomes and increase quality of life for women and girls living with HIV around the globe. And the way that we are aiming to do that is by providing accessible and comprehensive information through our fact sheets that are on our website, as well as community support, which we do through our online support groups and A Girl Like Me, as well as advocacy building such as our webinars. So as many of you know, you can access many of our resources and join the community at thewellproject.org. So about WATCH. WATCH is our Women's Advocacy and Treatment Coalition on HIV and is an ongoing HIV treatment advocacy and capacity building webinar series. This year, we have spread out the webinars throughout the year, and we've held 3 already in the earlier part of the year, and we have today's webinar as well as another one on November 14th, also around long-term survivors. And if you are interested in certification, hopefully you had participated on the 3 previous webinars or viewed the recording and taken the pre and post test for each one, and there will be a final evaluation survey at the end of the series, after which we will provide certificates of completion. And each of the webinars are recorded, including this one, and will be able to be accessed up to 1 month after they take place. And we will be working to provide a link to the webinar for everyone who participated today, as well as anyone who wasn't able to make it, on our website within a couple days, and we'll send out a notification as soon as that's up. I do see a question coming through, and are males allowed to take part in this webinar? And absolutely. Our resources, while they do have a specific focus on women, they are available and welcome to anyone. So yes, please. Okay, and for those of you who are new to this webinar series, please use the chat box on the left-hand side to, say hello to everyone and say where you're from. It helps presenters know a little bit more about who's online, and you can also use the chat box to enter questions throughout the webinar, which we'll keep track of, and we will be posing them at the end to the presenters. So each webinar will last about 90 minutes, and we will have the Q&A at the end. Excuse me. And if you're listening to the webinar via your phone, there's a 3-digit number after you dial in the code that you can enter. I think we're okay for this one. Sometimes that's more important if we're at capacity. So if you haven't entered that, do not worry about it right now. And the participants' lines will be muted until the Q&A. So if you would like to ask your question live, we will unmute the lines, and then you just have to press *6. Okay, so we are really happy to have a great lineup of speakers and panelists today. We have Dr. Kimberly Smith, who is the Vice President for Global Medical Strategy and Head of Research and Development for ViiV Healthcare. Mejia, who is a Global Ambassador community advisory board member, as well as a Girl Like Me blogger for the Well Project, but she has many other roles and is a very well-known social media advocate. And Tranisha Arzah, who is with ViiV Network and also is a blogger for A Girl Like Me. And again, this is Krista Martel. I'm the Executive Director of the Well Project. So before we start, I'm just going to ask each of our presenters, starting with Dr. Smith, to just give a little bit of an intro about themselves. Thank you.
Thank you, Trista. Well, you heard a little bit about me. I am currently work for ViiV Healthcare, but that's been only for the last 3 years of my life. Prior to that, I spent roughly 20 years as an HIV treater and researcher, and I like to think of myself as an advocate for people living with HIV, particularly women and people of color. And I'm really happy to be able to be here and chat with you all today.
Thank you, Dr. Smith. And Maria?
Yes. Hello, everyone. Good afternoon. Before I start saying what I do, I want to, for those that knew, the very young Bianca Parker passed away today. She was born with HIV, and unfortunately, complications of AIDS took her. So I just received the news, so I'm very shaken. She's very young and full of life. May she be in the light. So my name is Maria Mejia. I'm the Well Project's Global Ambassador. I'm in their Community Advisory Board. I love blogging for them. I'm a blogger, and I love representing them everywhere I go. I'm a motivational speaker and author. I sit on several advisory boards, including social media board for Janssen Pharmaceuticals as their spokesperson, and just helping them with their campaigns as far as HIV/AIDS and the CDC ambassador, a Greater Than AIDS ambassador, and so on and so on. Thank you. Happy to be here.
Thank you, Maria. And yes, very sorry to hear about the loss of this young woman. And well, I'll be sending love to you and everyone that knew her and her family. Tranisha?
Hi, y'all. Can you guys hear me?
Yes.
Okay,
Yes.
great. Sorry about the background noise. I'm in Seattle, pouring down rain in a local cafe. But my name is Tranisha Arzah. I'm a longtime survivor of 26 years. And I work at a program called ViiV Network, which is in the YWCA here at Seattle. And we provide services for women and families impacted by HIV. I'm also a blogger, also a NMAC youth scholar, and I'm just very grateful to be on this webinar. Thank you.
Thank you, Tranisha. So, so we've already, experienced a little bit of, what we're going to be talking about during these webinars, because we actually, when we did the fact sheet, developed this fact sheet, there's so much, kind of content to cover and different topics and issues that relate to being a long-term survivor that the fact sheet was kind of one of our longer fact sheets, but then when we were trying to, do a webinar and do some education and around this topic, we realized that it was kind of too much to put into one 90-minute session. So what we've decided to do is try and concentrate the topics today more about defining long-term survivors and talking a little bit about that, which includes those living or born with HIV, and then really kind of talk more about physical and treatment challenges. And for the next one, we'll kind of talk a little bit at the end about some of the topics that we're going to be talking about in the following webinar on November 14th, which is going to be talking about AIDS survivor syndrome, and some of the mental health issues related to being a long-term survivor, which includes PTSD and depression and trauma, and which includes having losing friends and family and loved ones back from the earlier part of the epidemic as well as even till now. So which is what we're just experiencing. So that is the agenda for today, and with that, I'm just going to read this quote from one of our bloggers and also a long-term survivor, Vicki Lynn. She writes, "We were a group of people who were willing to stand up for ourselves and for others and face what the world had to offer. Those living with HIV today can never imagine the horrors many of us had to endure in the early days of this epidemic. I wish I didn't remember. I wish I could forget." So now I'm going to hand it over to Dr. Smith to kind of walk us through some of today's topic.
Thank you, Krista. Again, this is a wonderful opportunity for me to be here and chat with folks. And so I'm going to go through a few slides just to set the context, and there's some polling questions that are built into to the slides just to give people an opportunity to sort of chime in. And then at the end, we'll open up the lines to have really, hopefully, a broad conversation and let people speak their minds about what they're hearing and what they're feeling, and to talk about the challenge that we're all continuing to face, but really to not have us start on a low note, to really think about how wonderful it is that we are now talking about long-term survival with HIV. And yes, there are challenges, but nothing that can't be overcome. And so I'm just really happy to be here and have an opportunity to chat. So I'll start with the first slide here that is titled Defining Long-Term Survivors. And so we know that powerful antiviral drugs now make it possible for people to live far longer than we could have imagined in the epidemic's early days. And for those of us that have a little bit of gray hair and have been around for a long time, we remember the horror of the early days. So the definitions here are pre-heart long-term survivors. So those are individuals who've been living with HIV since before 1996, which is really the start of the modern era of HAART, or highly active antiretroviral therapy. Prior to that, there was treatment, but not as effective as HAART. These individuals acquired HIV and recognized that it usually was a death sentence. They often spent the early adult lives believing that they would die young, that they wouldn't have an opportunity to grow old, that they wouldn't have an opportunity to live their lives fully. Post-HAART long-term survivors are people living with HIV for more than 10 years, but who were diagnosed after 1996. And so the experience for these individuals is different in the sense that HAART was available from the time that they were diagnosed. And it really has led to a different overall experience in that treatment was available. And so even though still there are many challenges with treatment and it's getting better, but certainly there were, even back in those early 90s, in 1996, HAART was available, but it was complicated. And so I don't want to make it sound like post-HAART long-term survivors had a utopia in comparison, but certainly the availability of effective treatment was known at the time in 1996. Other definitions that we'll talk about today, and just so everybody's on the same page when we use some of this language, perinatal acquisition are individuals who were born with HIV or acquired it as very young children. Some of these individuals are now in their 20s and 30s, having lived with HIV for decades and really in most cases for their whole lives. And they may have experienced the loss of many loved ones, sometimes individuals in their families or other friends or close relationships. HIV-negative long-term survivors are the partners, companions, activists, healthcare providers, people who have been a part of the epidemic, although not directly living with HIV, definitely impacted by HIV, and having experienced many losses I can say personally, having been treating HIV since the early 90s, I definitely experienced the loss of many patients, and so certainly understand exactly the feeling of, really having had major losses as a result of this epidemic. Okay, we're on to our first poll question.
Okay. The first question is, I consider myself to be a long-term survivor according to which of the following definitions? And then it will be the ones that were just presented. Okay, we will continue taking a couple more, and then we'll stop the vote in just a minute. So, interestingly, we have about 32% pre-heart, 20% post-heart, and 46%, well, it's shifting a little bit, of HIV negative long-term survivors. All right, thank you. We're going to stop the vote now. And just so you know, this does not count for anything, and it's anonymous, so it's just to help us kind of know who's participating today.
Right, so it looks like we have a bit of a smattering of many different folks who meet the various populations. And so I think this will be relevant to really everybody. The conversation here will be relevant to everybody that's a part of the conversation. Although it did not appear that we had anyone here who sort of met the criteria of perinatal acquisition, I think it's worth everyone sort of recognizing some of the challenges that exist. And we did hear the very sad story of Bianca, and she may be really sort of a perfect example of some of the challenges for individuals who acquired HIV at birth and have had many challenges. And so what's described here is that some of the studies have shown that individuals who had perinatal acquisition or acquired HIV at birth have had more challenges with being successful on treatment in comparison to adults. And some of that may be that they're exposed to HIV really even before they're born, and that may impact their immune system. It's possible that they could have acquired HIV that has some resistance to some of the drugs. And often young individuals can have very challenging family circumstances where it may be that they're not raised by biological parents. They may have been in environments that were more challenging. Often individuals may not be in two-parent homes, maybe in environments where they're raised by individuals that they don't know their full family, or they're disconnected. And then with all of the challenges that come from living with HIV as a young age, people may have more challenges with adherence, and that has been described really quite frequently. Adolescents in particular, we know, have a difficult time consistently taking medications. Often they have, competing things going on in their life with dealing with school and other things. And so taking HIV medicines may not be the first thing at the top of their list. Physical health concerns of long-term survivors. Well, so there's some data that some of the effects of aging may be a little bit different for individuals that are living with HIV. Long-term survivors of all ages have to have trusting relationships with their healthcare providers, and those are really important. It's critically important that you actually have regular conversations with your healthcare provider and talk about some of the challenges of living with HIV and some of the symptoms that you may be experiencing. It's those conversations, it's that relationship that allows you to get onto a regimen that is the most tolerable, one that works well for you. And that happens from just having ongoing conversations and having a really good relationship with your provider. Some of the HIV treatment challenges: many long-term survivors deal with the consequences of decades of HIV treatment. So as I mentioned, some of the earlier treatments came along with some really challenging side effects. Treatments are better now, but some people are still having some of the effects of treatments they may have received in the past. Again, some of these medications include, some of these side effects include things like lipodystrophy or body fat changes. People may have had surgeries to try to correct some of these, or they may have had implants or injections to correct some of the changes in fat. So, for example, facial lipoatrophy, where people tend to have a loss of fat in the face and have their face appear to be more thin, or the cheeks more sunken. People have used a number of strategies to try to improve that. In some cases, they're very successful, and in other cases, people may have scars or challenges related to those. And then peripheral neuropathy was a very common side effect from some of the early medications. And even though you may not be on that medication anymore, some of the long-term impact is that the nerve damage that was done from those medications can persist long after someone is on those medicines. Treatment fatigue.
Do we want to stop maybe at this point and ask Mejia and Tranisha to also share, just based on some of those challenges, any perspectives that they've had or personal experiences?
Great. I think that's a great idea.
I would like Tranisha to start because she was born with HIV, which is what we were discussing before, then I could take it from there.
Okay.
Yeah. I can definitely relate to a lot of those things around treatment, fatigue. There was a point in my journey with HIV when I was around 18 that I actually did stop taking my treatment on and off for about a year. And that was a really, really difficult, hard time for me. I think as like a young person, I was dealing with so many different things, and I definitely put HIV on the back burner for a while. It was also a time where I was dealing with my HIV by myself. I didn't have my parents or to support me, and so it was definitely a learning experience.
Tranisha, can I just ask you a follow-up question about that? What was your relationship like with your provider?
Sorry, what was that?
I was just asking, what was your relationship with your provider like? Was it a good relationship? Have you had a good relationship with your provider? Is that helpful?
Yes, most definitely. In my slide, I'll be talking a little bit more about that when it comes to folks living with HIV. But I have experienced providers where we did not have a relationship that worked for me personally. I think being able to be comfortable with your provider, we're discussing such personal things, especially being a young person, it can be hard to talk to adults anyway, back when I was a lot younger. And so now I have a great provider where I feel like I can disclose anything. I don't feel like I'm being judged by some of the things I might be doing for whatever reason. And so, yeah, definitely having a good relationship with a provider is vital to one's health.
Yeah, I can imagine transitioning from kind of like the pediatrician. Yeah, sorry, Mejia, go ahead.
No, it's okay. So as far as my experience, I was not born with HIV, but I acquired it when I was a teenager. It was very, very hard for me. It was in that time where it was a death sentence. I come from a very conservative Latin American background from Colombia, and there's a lot of complexities that we have as long-term survivors. That's why I'm so passionate about it. But in the first 10 years, I was told by my mother that I could not disclose because they would discriminate me. I went back home to Colombia in South America to die. We had no access to treatment. We had no internet. We had no support groups. I didn't know anyone that had HIV besides myself. So I had to live with that shame and that silence and that feeling, like the doctor mentioned, that I was going to die. It was like I would go to medical libraries every day for the student medical libraries to try to get my hands on every information that I could find as far as HIV and AIDS, and that's how I kind of like taught myself. Around in 1996, unfortunately, HIV medications did reach Colombia, and it was the high dosages of AZT, the Xeris, the Ibid, you know, the horrible ones that caused all those side effects. They were very, very toxic, and I remember a doctor asking me to sign a waiver because the large doses of AZT could damage my internal organs. And as a teenager, I kind of processed that, and I said, no, I don't want to damage my organs. So what I did was take natural things for the first 10 years because my mom has a health food store. I did everything that I could, even to survive, even to drink my own urine for 3 months. It was supposedly a Japanese therapy. Any that know my story know that, and but as everyone knows, if you don't take your HIV medications, you will eventually die. And I have a doctor, a physician in my family, have many, but one of them I did disclose to. And around that time, which was the year 1999-2000, he tested me, my CD4 count, because the viral load test wasn't even available. It was very costly, and I had 39 T cells and cancer in my uterus, so I had an AIDS diagnosis. I came back to the United States to try to stay alive. I was, you know, the doctor pretty much told me I had 1 month to live, that if I didn't take my medication, I was going to die, and I wanted to live. That's why I'm such a passionate about, you know, treatment advocacy and being an advocate for yourself. My relationship with my doctors are very important. Every time I speak to providers, I try to tell them that it has to be a mutual respect with each other because it's like a marriage. Most likely we'll see that doctor for a long time. And if the doctor does not respect you, or that maybe you want to be proactive and research what you're putting in your body, you could fire that doctor. You have to have a good relationship because just like a marriage, if you don't have communication, you will get divorced. So even though I have been very adherent for the past 17 years on HIV treatment, it's getting harder for me and for my long-term survivor friends. All of us have discussions. We have a group where we talk about it. Yes, we are alive, but as I tell young people that are not respecting this virus, it's not a death sentence anymore, but it is a life sentence. This is not an easy thing. Aging with HIV is not easy. I have severe neuropathy. I have pain every day, inflammation. It's extreme fatigue, pill fatigue. I cry. I grieve. I have a friend that, like I mentioned, passed today. Last month, I lost 5 long-term survivor friends, and I have some that are sick right now, and it scares me because we'll talk about that in the next webinar about the mental illness part of it. And I'm not going to discuss it now, but we're like soldiers that came back from war with scars. I've had to go through plastic surgery. I've had lipoatrophy in my legs, in my buttocks area, in my face. Thankfully, my uncle's a plastic surgeon. I really don't talk about this, but, you know, I guess I shouldn't feel ashamed. I was just trying to maintain the body that God gave me. And, you know, trying, you know, even though I look good on the outside, people don't understand what I go through in the inside. Now, do I have good days? Yes, I do, but it's not an easy thing. And it is getting harder for me with aging. So, I mean, there is hope, you know, especially for the newly diagnosed and for those, like the doctor mentioned, you know, our medications are less toxic. Maybe they don't have those scars, those mental scars of so much loss and all these different variety of things. But, you know, we have to continue on. We have to think positive. I'm grieving right now, so of course I'm not going to have like this positive. I feel very sad right now and scared because every time a long-term survivor passes, I feel like, when is it going to be me, or why wasn't it me? You know, like the survivor's guilt. So, you know, there is hope. As I tell people, we're not sick. We're just surviving and thriving.
Thank you, Maria. That was you know, it was wonderful that you're sharing in the way that you are, and I think you made a couple of really important points. One was about the relationship between the patient and the provider. and describing it like a marriage is, I think, a great way to do it. This is, I will say, this is the first time I've thought of myself as a polygamist, but it's good. and that you really should have a great relationship with your provider. And if you don't, then it's important to feel empowered to tell that provider what about the relationship is not working for you. And if you can't get it to work out, then find another provider that does work for you, because that relationship is very important. And so I just want to underscore that point.
Thank you,
so I'm going to go back to the slide and take us to a couple more points, and then I think we have a poll coming up to ask a few more questions. So I think these slides are bouncing around. There's a ghost. And so treatment fatigue and treatment tolerability. So treatment fatigue is something where you basically, having the commitment to have to take a medication every day, and in some cases multiple times a day, and in many cases multiple pills a day, and sometimes with side effects associated with those, can be really tough to do over the long term. It's not like when you have a pneumonia and you take medications for a week or two and then you're done. Obviously, this is taking medications every day, and the challenge of knowing that they're going to be taking medications for the rest of your life can be really tough for a lot of people, and the frustration that comes from that is real. And so that's something to sort of try to work through. Multi-drug resistant HIV is when the virus basically becomes resistant to some of the medicines, and that can happen when you're not consistently adherent with taking the medications. And so if you take significant breaks, and so you skip medications a few days a week, or you just take a long holiday from taking medications, or take the medications in a way that's different than the way they're prescribed, can sometimes lead to the virus basically becoming resistant to the medications. And when that's the case, that means you have to go to a new set of medications. And even though we have a lot of medications, there's more than 27 medications that are approved for HIV, they tend to be in classes, and so sometimes you can get resistance that knocks out not just that medication that you're taking, but other medications. And so if this happens a lot, it can lead to having a virus that's tougher to treat. So, and we talked already about the fact that in the past the medications were more difficult to take. Nowadays, they tend to be medications that are easier to take with fewer side effects and fewer times a day, which hopefully helps with some of the challenges around treatment fatigue. The last bullet talks about long-term survivors may take several pills a day, and there may be a need for medications other than for treatment of things other than HIV. So some individuals may have hypertension, and diabetes, maybe hepatitis C or B, or other comorbid conditions that mean taking other medications. And so adding pills adding to the need to take more pills can often be a contributor to having challenges with side effects from medications and treatment fatigue. Okay, so Krista, we're on to our next poll question.
Okay. The next poll question is approximately how many different HIV treatment regimens have you taken? And we have categories, and some this may not be applicable, and some may not be sure. Okay, so of those who are answering of the how many regimens, the largest percentage is 5 or more, so at 25%, which is a lot. And then we have some that have been on 1 to 2, and 7% that are on 3 to 4. So, and then we have 48% that are not applicable. So, okay. So I'm going to close the vote now, and I'm going to turn it back to you, Kim.
Okay, so that's really good to know that we have sort of a wide variety. So the most fortunate folks are the folks who've had to be on only one or two. So hopefully that means that the first regimen or the second regimen that you were given worked well for you and that you're tolerating it well. And folks that have been on 5 or more regimens, that's challenging it. It often means that there were, maybe it means that you were one of that group that was diagnosed before 1996, and so you've had some of the earlier medicines. But hopefully it also means that now you've moved towards being on some of the newer medications. And so hopefully there's an evolution, and we'll get to some of that when we get to the question and answer, but that there's been an evolution in the tolerability of the medications that you're taking. Hopefully you're in a place now where you're on medicines that are working well for you and being tolerated well. Okay. Back to our slide. So inflammation. So inflammation is the body's natural response to a threat or to damage. And so the immune system is, if HIV is attacking the immune system is always basically trying to react to it. And so you can think of the immune system as always being turned on. And so inflammation is is something that is good when it's reacting to the flu, or it's reacting to a bacteria that you may be exposed to, because the immune system gets turned on and can get rid of that infection. But with HIV, unfortunately, the immune system is not able to get rid of HIV. But that doesn't mean that it stops reacting. And so it's that constant reaction to HIV that leads to some of the symptoms and some of the impact that people who are living with HIV for a long time can have. So it may be that chronic inflammation, so chronic meaning being there for a long time and not going away. So chronic inflammation has been associated with some of the HIV-associated illnesses, like HIV-associated heart disease, or maybe a predilection to having more heart disease among individuals with HIV. Some cancers can be associated with having chronic inflammation, and other symptoms like bone disorders, in some cases kidney disorders, can be associated with the chronic inflammation. And it's important to note that HIV is one of the conditions that causes chronic inflammation, but there are others. So like rheumatoid arthritis, for example, is associated with chronic inflammation. Your body is attacking your joints. It's a disease. Your body thinks that the joints are foreign, so it's attacking all the time. Lupus is another example. And so it's not just HIV, but HIV is certainly a good example of a condition where there's chronic inflammation. So the next slide talks about this question of accelerated aging. And so the concept of accelerated aging is the question of whether or not people who are living with HIV have experienced signs of aging earlier. And so instead of some of the symptoms of aging occurring when you reach your 60s, are they occurring when you reach your 50s or maybe even 40s? And I can tell you that this is actually a pretty controversial question. And so there had been some suggestion that people who were living with HIV were experiencing diseases like heart disease way earlier than people who didn't have HIV disease. And some of the big cohort studies from people around the world who've looked at this question have fallen on both sides of this argument. In some cases, some studies suggest that maybe people are experiencing some complications of HIV or experiencing aging-type symptoms like bone disease and heart disease at an age earlier than people with HIV that don't have HIV. But other studies have shown that it's not that they experience it earlier, it's just that it's more common. And so heart disease is more common in people living with HIV disease, but it occurs at ages that are similar to people who don't have HIV disease. And so it's complicated, but the long and short of it, I think, whether or not it's accelerated or it's just maybe exaggerated or more frequent, nonetheless, it is something that is well recognized. And so what does that mean? Well, it means that the types of risk factors that are associated with things like heart disease, so like smoking, high-fat diet, lack of exercise, those types of things in a person who has HIV disease may be even more impactful, may make you even more likely to have an HIV, to have a heart attack. And so if if you're living with HIV disease, it just emphasizes you should do all of those things to try to minimize those risks. So trying to eat right, try to be healthy and exercise, try not to smoke, limit alcohol, all of those things that you can do to try to make yourself healthy, they work for people who are living with HIV disease just like they work for people who are not living with HIV disease. So it just says, basically, yes, you may be more vulnerable to some of these things, but it's not an insurmountable challenge. Krista, we have our next poll question.
Yes. Okay. So this is our third and final. So based on what Dr. Smith was saying, that there's research that's showing both sides of the coin, and so we're just curious where you fall. Do you believe HIV causes people living with HIV to age faster? Yes, no, or you're not sure, based on your personal experiences. Okay, so right now we're still keep it open for about 10 more seconds, but we have about 2/3 who believe it does cause people living with HIV to age faster, and about 1/3 who are not sure, just a small percentage who say no. Okay, I'm going to close up the voting now. Thank you.
Great. So that's very interesting. So again, like I said, sort of if you pay attention to the literature, the answers are all over the place. But it is certainly well recognized that some of the things that we associate with aging, like cancers, heart disease, those sort of things, are more common in folks with HIV disease, and in some cases may be happening to people at younger ages. Okay. Next, back to our presentation. So comorbidities. So comorbidities, to define this word, are basically other diseases that someone may be living with other than HIV. So that examples of this may be heart disease, hepatitis C, other types of liver disease, renal disease is another example, and so some of these can make living with HIV even more complicated. So it means that you're taking medications not just for HIV, but also for these other things. Heart disease, to talk about these in a little bit more detail, heart disease is more likely among individuals who've taken some of the older HIV drugs. And so some of the older HIV drugs made your cholesterol go up and may be associated with being more likely to have heart disease. They also have been associated with some of those body changes that we mentioned. Hepatitis C, as we know, some of the same things that put people at risk for HIV also put them at risk for hepatitis C. So if a person acquired HIV from drug use, particularly injection drug use, they may have also acquired hepatitis C. Or if a person acquires HIV and they continue to use, they may acquire hepatitis C later. It's also possible to acquire hepatitis C from sex. And so we recognize actually lately there's actually been quite a big epidemic of hepatitis C among men who have sex with men with sexual transmission. And so we know hepatitis C can be transmitted both from drug use, injection drug use, from sex, and in the past, people acquired acquired hepatitis C from blood transfusions. Nowadays, blood is tested for hepatitis C, so that doesn't happen if you get a blood transfusion now. But many years ago, before it was recognized that you could test for hepatitis, before you identified the ability to test blood for hepatitis C, it could be transmitted through blood transfusions. Other types of liver disease, well, some of the HIV medications themselves can be associated with liver disease, but also we know that alcohol use and use of drugs can be associated with liver disease. Also, there's something called NASH, or non-alcohol associated fatty liver disease. It can happen with people just from being overweight or from having a really high fat diet, and that is also another cause of liver disease. So all of these things can be complications that people who are living with HIV may also be dealing with. Brain problems. So one of the things that is known about HIV is that it also can cause something called HIV-associated neurocognitive disorder, and the shorthand for it is HAND. And so hand is basically the impact of the virus on the brain. It is affecting neurons. It's affecting the brain's ability to function. And so some of the symptoms of that are people can be a little bit more forgetful. Sometimes people can have a tremor. People can have challenges with, if it becomes very progressed, can have challenges even with difficulty walking. And so when it gets to be very severe. And so that's one of the things that can happen with HIV. Now, importantly, hand is more common in people who aren't on treatment. And so people who are on treatment are much less likely to get hand. And in some cases, treatment makes hand get better. And so, but it is one of the things that is recognized to be present in some long-term survivors. Cancers, we've talked about that. There are many cancers that are more common in people who are living with HIV disease. Some of those are age-related cancers, so cancers that you get because your immune system is weak, but even other types of cancers that are common in a non-HIV population can happen in individuals with HIV. So breast cancer and lung cancer are described here as options. That's true of colon cancer and other types of cancers as well. Bone disease, some of the HIV medications can be associated with bone disease. HIV itself can cause individuals to have bone disease, and so individuals that have been living with HIV for a long time and taking medications for a long time can have bones that are a little bit more fragile. So that means it may be easier to have a fracture with you don't have to have a severe injury in order to get a fracture. You could get it with a less severe injury because the bones are a little bit more fragile. Next slide talks about menopause, which we often refer to as sort of the change of life. And so this is the point in a woman's life when her menstrual period stop. And so this is a period basically where there are major changes in the hormones in a woman. And so the estrogen hormones tend to be low. And there can be a lot of symptoms that come along with menopause. People can have hot flashes. They may experience fatigue. They may experience, this is another thing that can make people's bones more weak. And so menopause can be treated in a lot of different ways. Some people take hormone replacement therapy. Some people use herbs or other vitamin-type treatments to mitigate some of those symptoms. But one of the key things here is that, you know, it's a part of life. And there's probably many people, many women in particular, who are living with HIV think about their mothers having menopause, and when they were young and diagnosed with HIV, they thought that they would never experience this in their life. But as long-term survivors, they're experiencing the same types of things that people who don't live with HIV have. Menopause is one of those.
I'm going to pause for just 1 second and see, back up a little bit and see if Mejia and Tranisha have, you know, any personal experiences that they want to share about, you know, any comorbidities or diseases or illnesses that they've had to, you know, had to deal with or are dealing with, that they would, you know, just to kind of lend some personal experience to that.
If you want, Tranisha, you could start.
Okay. Can you guys hear me? Just want to make sure.
Yes.
Yes.
Okay, great. Yeah, so luckily, I haven't experienced a lot when it comes to issues with my organs at all. But growing up as a young kid, I definitely had issues like with my joints at an early age. Luckily that has gone away. And I definitely experienced inflammation. Nostrils, I have inflamed gums, which has also caused chronic allergies that I will probably have for the rest of my life. So I've been dealing with that mostly when it comes to breathing through my nose, and just dealing with like being allergic to everything because of the inflammation that that I have. But these are some of the things that I experienced.
Mm-hmm. Thank you.
And well, it's Maria, and my experiences, as I mentioned before, is with neuropathy, you know, with the nerve endings in my feet and in my hands. I have to be on pretty much, as the doctor mentioned, I have a lot of, not only my HIV meds, but I have like 8 other medications that I have to take for different things. A lot of us suffer from high cholesterol, and we have to keep that, in check. Even though everyone that knows me knows that I am like a health freak or something. I exercise a lot. That has helped me a lot as far as my anxiety and even with my pain. Because like Tranisha, with the inflammation, I also have allergies constantly, and just everything hurts from head to toe. I don't know how to describe it. And now I have this new thing going on that I'm even scared to go to the doctor, a hand specialist actually, and I'm afraid that it's going to be what the doctor mentioned, which is arthritis. I'm having problems closing my hands hurt. And I'm very scared because, mentally I am drained. A lot of this thing has to do with not only the physical, but the mental. And sometimes, like the other night that I was in so much pain, I told myself, I said, I'm tired. And it's okay to feel tired because we're human, But the thing is that you cannot stop. At least I cannot afford to stop my HIV medications because I know what it feels like to be almost dying. And not only that, I'm what you called an immune non-responder, and I'm serodiscordant. That means I have been virally suppressed for 17 years, but my immune system never has really recovered. And my percentage in my immune system is pretty low. So I can't give myself that holiday or say I'm just not going to take my medication because I know how important adherence is, and I just can't risk it, just to have like a week or 2 weeks of not taking my medication and then end up in a worse situation. So yeah, there's, my hormones also. Of course, I am 43. I believe I'm in premenopause. My menstrual, period is not, it's very, it's on and off, and it's every 25 days, every 28 days. I bleed in between periods. I'm right now checking a polyp. As I mentioned, I'm a survivor of cancer in the uterus. Now I have a polyp that they're monitoring. So it's like all these different things and I have a lot of fears, which is something that I'm trying to work on as far as meditation and exercise, because that fear that I've always had ever since I was diagnosed has not gone away. And seeing my friends, get so sick and things like that, I suffer from a lot of anxiety and a lot of things that we will talk about in the second part of this webinar. But yeah, it's, we just have to continue on. What can we do? We can't, we have two choices, and this is how I really believe it. We either continue fighting and try to live the best life that we can with the things that we're dealing with, or we either just lay down and die. And you're just not going to lay down and die. You're most likely going to get very sick and suffer, So I choose to be adherent and to continue fighting until the end.
Thank you.
All right.
Thank you.
Yeah, it is hard I know that we have kind of tried to set this up just from a time perspective to separate some of the physical from some of the mental health issues, as Maria's talking about, and fear and anxiety and a host of other things. But obviously they're very interrelated, and but we are just, for time purposes, we're going to try and focus. But thank you for continuing to bring that up, as it is very much related.
Okay, so we'll go back to the slides, and then the next slide that we're on is sexual health, and this is a really important one. I think everybody has the myth that older women don't have sex, or don't have an interest in sex, or older men, or anyone, that older people in general don't have sex. Well, that's a myth. And I was very aggressive about talking to my patients about their sex lives. They probably thought I was nuts because I would always ask them about their sex lives. But that's because people living with HIV should be able to have normal sex lives. And I wanted to encourage people to have normal sex lives. One, because part of being an adult and being a happy adult is being able to have a partner and be able to have intimacy with your partner. And two, because I know that people deal with a lot of stigma related to HIV, and that they become very fearful of having sexual relationships. But we know that it's certainly possible to have safe sex living with HIV. And the data that exists now, it tells us that that when individuals are on antiretroviral therapy and have an undetectable viral load, their likelihood of transmitting to their partner goes very, very close to zero. And so people should feel comfortable to be able to have active sexual lives. And so it's important to make that be an important part of people's life and to encourage that. And so I said that that's something that I do, but I do know that that's a challenge for some providers. Some providers don't feel comfortable asking their patients about their sex life, and that is, I think that sometimes is a loss. And so if your provider's not bringing it up, it's good for you to bring it up. And so talk about, what your desires are. And for men, I mean, there's no reason why men who may be having challenges with having difficulty with sexual function, I had no problem in giving my male patients Viagra or other medications like that to help them have healthy sex lives, and talking to my female patients about basically just being your natural self and being a sexually active person. In some cases, women are interested in being sexually active with a partner and not becoming pregnant, and so having safe contraceptive resources and information is important. And so asking your doctor about what are the best contraceptives for you. So if it's something that you might take other than using condoms, but if it's something you might take the pill or might be on long-acting contraception with a depot shot or an implant or something like that, just talk to your doctor about what good options are. And then for women that are young and still of childbearing age, so many women who are living with HIV believe that means they could never have a child, and that is absolutely not the case. And so, again, similar to not transmitting to a sexual partner, it's also true that women who are living with HIV and on antiretroviral therapy can become pregnant and can deliver healthy children who don't have HIV disease. And so I've always talked to my women who are of the age, of childbearing age, about what they want. And so I don't let any doctor tell you that you can't have a child just because you're living with HIV disease. I'll move on to our next slide, and we'll talk. I'm sure that will promote some questions, so we'll get to that at the end. Okay, this slide is talking about AIDS survivor syndrome, and so Maria talked about this somewhat, and this is, I mean, I think it's probably a good way to describe it is to think of it as a PTSD or a post-traumatic stress disorder. Basically, the experience of living with a disease that can kill you, and living with a disease that has killed people who are around you, and knowing that that's a part of your life every day can cause some anxiety and can cause a lot of symptoms. You've seen here on the right side of the slide the description of some of these symptoms: anxiety, nervousness, this feeling of sort of constantly being on guard, always being worried about something happening, sometimes depression, irritability, fear that there's not going to be a future, so worrying about there being a future, having low self-esteem, so being impacted by the stigma that's associated with HIV disease. Sometimes that means people self-medicate with medications, either prescription medications or other substances, and so that can lead to abuse in some cases. And this was probably the most common, is social withdrawal and isolation. Although I mentioned the fact that I talk to my patients about having sex, a lot of my patients said they didn't want to date. They didn't want to disclose. They were worried about talking about HIV. And so I think that is really part of that experience of still being associated with the stigma of living with HIV. And then the last point is mentions the concept of survivor's guilt. And so Maria described this very well. She said, I sometimes wonder, why when bad things happen to friends of hers who are living with HIV disease, why is it them and why not me? And so that is something that many people experience. And so, I think recognizing what's happening to you is important to be able to talk about it to your doctor, talk about it to your friends, and talk about it even to other individuals who are living in similar situations. I think that's my last slide, and so the next couple of slides, I'm turning it back over to Krista and Mejia and Tranisha.
Thank you so much, Dr. Smith, for all of your, the great presentation as well as your personal experience and kind of helping everyone see what, a model doctor in HIV is. So I almost wish I had a poll question around some of that, what you're talking about, to see how many of the people on the webinar also had doctors who are actively asking them about their sex life and different things, and their and making sure that they are engaging with others and not isolated. So I am going to now ask Tranisha. We wanted to, before, as I mentioned, a lot of what we were talking about just on that last slide with AIDS survivor syndrome is going to be what we're going to be diving in deeper on the next webinar. And so we really hope that everyone can come back and be part of that one as well, because it is really all very tied together. But we wanted to, before we go into Q&A, also kind of talk about some positive steps. And I know Maria's talked a little bit about exercise and meditation, but Tranisha's going to talk a little bit about a few things here, and as well as some of her personal experiences, and then Mejia will do as well.
Yeah, thank you, Dr. Smith. I really appreciate all that information. So this is my favorite, or one of my favorite slides, because we can, like Krista said, we can talk about some of the positive things. So for long-term survivors, we are definitely resilient people. And for me, it's not just about surviving with this condition, it's about thriving with this condition. We're going to be, throughout our long life with HIV. And these are some of the practices that one living with HIV, the long-term survivor, can introduce in their journey. So first, taking charge of your health. It sounds pretty simple, but it can be very, very difficult. And some of the things that we can do is, learn about the medications that are continually coming out, the medications that you're currently on, and ask those questions. For me, asking questions that I might not understand or might not be at a level that makes sense to me, I will always clarify with my providers and case managers or want clarification. So having a good relationship with these healthcare providers is vital to one's health. I talked briefly about that when I didn't have a good relationship with my doctor, my health declined. So it's really important. And also keeping up on diet and exercise, that came up in the earlier slides. And whatever that looks like for that individual, I know exercise is something that I'm still struggling with. As we age, weight usually occurs and other complications. So, and I think that's something that we can work with our providers so that we're in the best shape that we can be in. Getting support. This is my favorite thing. As someone who is a peer advocate, having a support system is really, really important. Whatever that looks like, a mental health counselor, a peer mentor, peer advocate is what I call them, going to support groups that can help provide that support. And also helping get connected to activities in your community is also a great way to get support. And also, lastly, tell your stories. So speaking the truth is part of healing, which is very, very true. As resilient people, for me, when I started telling my story, 26 years of living with HIV, it really allowed me to dive into my own trauma that I experienced and started that healing process. So when I started sharing my experiences, I was able to gain better understanding of where I am now. I gained a lot of strength, a lot of confidence, and that can look like many different ways. It doesn't have to be in front of the audience. It can be online, through the Well Project. It could be through Positive Women's Network, PSA. They also accept blogs for women with HIV. There's many ways to share your experience, and I definitely suggest folks that want to dive into that to look into that.
Thank you, Tranisha. It's really great to hear how your, story and experience of making some of these changes and, still working on them and some of them. I mean, it's hard to do everything and still be just living your life. There's a lot going on, so we appreciate hearing how you've been taking charge. And Maria, I know before we move on to the next slide, I know you've been talking a lot about how exercise has kind of really had an impact lately on helping you, and so maybe you want to speak to that before we move up to the next slide, or anything else that's on this slide.
Yeah, absolutely. Even though I have discussed today kind of like the dark side, because again, I mean, I just received some news that's devastating, of course, when any of our brothers or sisters passes. I'm a very optimistic person, even when I'm going through a tough time, and that's how I've been since I've been a child. The best recommendation I can give people is, we're constantly fighting the virus. So the most important advice, besides even exercise or anything, is adherence. Continue keeping that virus dormant, so it does not attack our immune system. Always go to get your blood work, be consistent with your doctor, have a good relationship with your doctor. As far as exercise, this is something that I know it was a good thing for me, but like Tranisha, I was struggling with it, but after a while I became kind of like addicted to it, and it was a good addiction. It's not excessive either. I work out, I do cardio, I lift weights, I'm training to do a triathlon, believe it or not, even though I have pain and everything. Somehow when I exercise, the pain is less. My mind is more clear. I feel better about myself, not only physically, but mentally. As far as the spiritual side, I pray, I meditate, I try to, sometimes I may not have maybe a mountain to see, but I could go to the ocean, or just put, different meditation sounds and chants, that I could listen to and chant to. It balances me. And having a positive mindset. Yes, it's very hard to kind of be positive if you're going through a lot of pain a certain day, but just know that every day is not going to be that way, and that there's going to be a better tomorrow. So we just have to continue on fighting and surviving and thriving, and sharing your stories with others, empowering them to share their stories as well, as Tranisha mentioned, through the Well Project, through PWN, through support groups that we have in Facebook that are so important, because we need each other. We're all in this together, people that are infected and affected. So let's just continue on fighting and eat healthy. I juice a lot. That gives me a lot of energy, and yeah, just try to have a support system, which is very, very important as well.
Thank you. And then on this next slide too, there's a few other insights to committing to an activity that excites you, whether through work or volunteering, and we've seen a lot of people evolve, from after being diagnosed with HIV and starting to become more active and empowered and really, like it says, take your rightful seat at the table. So Maria, I don't know if you want to also, or Tranisha, talk a little bit about this, but kind of how making sure that your voice is heard and being part of the discussion and sharing the experiences has empowered you.
If you want, you could start, Tranisha.
Okay, thank you. Yeah, again, finding a purpose. To me, that was sharing my experiences and talking about it. I'm actively involved in my community here in Seattle. So I really do think that's part of my purpose, so that I can help other women and just people in general, young people who are negative or living with HIV is really, really important to me. So I am actively involved, and so that definitely helps with my healing. It helps with learning more about this condition. And I'm on the board of Positive Women's Network, so I think that's a great way to, for me personally, to understand the policies behind everything, understand that we are experts in this. We should be making the decisions. We are powerful. And so I have participated in PW1 events. I have been writing blogs. I go to AIDS Watch, which is a annual policy decision advocacy event that occurs in DC. And so if you haven't applied for that, do so. It might be still open, but and that's really helped me learn that there's a lot more going on, and learn that we do have the power to change things for the better. So I definitely advocate folks to advocate for themselves and advocate for others.
Thank you. Yeah, PWN is one of our partner organizations, and we definitely advocate for people to kind of on the policy and advocacy level to really check out what they're doing and see if there's a space that you feel interested in making those changes. So, and Maria, anything else you want to share around this?
Yeah, basically kind of like similar to Tranisha. Well, to me, one of the things that I did, besides, of course, blogging for a girl like me, which is so important, we're all, women that are connected and empowering each other and learning from each other's experiences, but also one of the founders of the largest online groups in English and Spanish and Facebook. Both of them have a connection of almost 40,000 active members and growing. And that was very important to me to create many years ago, because I always said to myself, what could I create that I didn't have when I was diagnosed? And support system, as I mentioned before, was one of the most important things. Also, I have a lot of access to mainstream media, thankfully, because I believe that we shouldn't talk about HIV only when it's World AIDS Day or when maybe a movie star comes out saying that they have HIV. So I utilize the tools of social media besides the community work that I do since the year 2000, which is, like volunteering for the Red Cross, and as a tester and peer educator in Jackson Memorial Hospital, ACT Immunology. And those are things that kind of like built the activist that I am today. But that also, in helping others, I found that I was helping myself because it gave me a purpose, and it gave me a mission. And my mission is very, very simple, is to give hope to the hopeless through me, and to save lives and prevent HIV infections, also through my story and my other peers' stories as well, because it is very important for people to humanize this condition. And that's why it's so important for me to reach that mainstream media, radio, TV, magazines, and things like that. Not to, no one wants to be famous for having HIV, but I feel that it is my moral duty. And if I could do it, I'm going to do it and show my face and show people that we're not dirty, we are not unclean, we're not untouchable, we're just human beings that happen to have the condition of HIV.
Thank you, Maria, so much, and to Tranisha and Dr. Smith for everything. I think it's really powerful to hear kind of the issues laid out, but then, these personal experiences as well as successes. So I'm going to read off some questions that have come through, and if anyone else has any other questions or something they want to share, we can open up the lines after we get through a few questions, or you can put them in the chat box. So someone asked if anyone can speak to some examples of nerve damage from peripheral neuropathy.
So Maria, you want to maybe talk about your symptoms, and then I can just talk a little bit after.
Yeah, I think that you would be probably the best to describe it. The neuropathy, as far as the symptoms that I feel, is numbness and tingling in my fingers and in my toes. And I know other people that they have it even worse than you were. They can't even walk, so they're put on these Neurontin or Lyrica, and they do help with the pain, or even painkillers, opiates, which it's kind of like, we'll talk about that in the second part, because you also could misuse that medication because you want to numb all those other symptoms that we will talk about. But yeah, I think the doctor is the best person to kind of like describe what I'm going through as far as that.
Well, Maria, you described the symptoms perfectly. So, peripheral neuropathy is one of the potential complications of HIV, but really more so of HIV medications. And so some of the medications that were associated with peripheral neuropathy include D4T or Xerit. People may remember it as being that. Stavudine is the other name for it. Also DDI or didanosine or Bidex was the name for it. So those two medications in particular were associated with peripheral neuropathy. And so people have symptoms of sort of feeling like, probably a good way to describe it, you ever feel like your foot goes to sleep and you feel that sort of numbness or tingling that's down there, and you just kind of want to shake it to kind of make it go away. Well, it's like having that symptom almost all the time. And so more commonly people experience it in their feet, but they also in some cases can experience it in their hands. And so Maria also described a number of the treatments that have been tried for that. Neurontin and other medications are used to try to contain that nerve pain, and in some cases it can be very effective. Some people, when they stop taking the medications that are associated with the neuropathy, their neuropathy gets better. In other cases, particularly if people have been on the medication for a long time, the symptoms don't go away even after being on the medication. And so, but this is something where if someone is having symptoms like this, so Maria, it's important to actually go see a neurologist, because there are a lot of newer medications that are available that may be helpful with some of those symptoms.
I will. Thank you.
Thank you, Dr. Smith. One question came in, but a few people, which is one of the things we love about our participants, sometimes a question comes in and we have other participants that jump in and provide answers before we get to it. So a question about a blood test that can inform a doctor about how long-term treatment can affect the liver. And so people were commenting and providing resources around, how you can request, liver panel tests that would indicate if there were problems with your liver. But another related question came in about how long it could take for antiretroviral meds to, like, how many years or, how long it would take before it starts affecting, ARTs affecting the liver, and especially as a long-term survivor.
So not all HIV medicines affect the liver, and even the ones that have been associated with some liver disease, they don't do it for everybody. So it still happens for a small fraction of people. And so for any of the medications that make it to the market and they stay on the market, they may have side effects of liver disease, causing some liver disease, but again, in a small fraction of people. And so the question around how would you know? Well, when you're seeing a doctor regularly, those liver tests should be done on a regular basis, at least twice a year. And so if the liver test were to come back looking abnormal, then your doctor would try to figure out why that is. And so is it related to medications? Is it related to having some other comorbid disease like hepatitis? So your doctor should be figuring out what's the cause of those liver problems. And if it turns out that they don't find anything and they ultimately think that it's the medication, then they should switch you to a different medication that won't cause that problem. And so, like I said, not all the medicines cause it, and even the ones that have been associated with it in some people, it's a fraction of people that have the symptom. And so then the last question someone asked, well, how long does it take before it causes a problem? Usually it sort of, you can tell if it's going to cause a problem relatively soon after a person starts on the medication. And if you don't have the problem in the short order, then it's unlikely that you're going to have the problem in the long term related to a medication. I hope that answers the question.
Great. Yes, I think that was a great answer. So we also had a question about, in terms of hand, or, pain and bone problems, and asking if AZT could be the culprit. And there was kind of a secondary comment around how anemia wasn't mentioned in the comorbidities.
Mm-hmm. So I'll answer the first question first. So can hand or HIV-associated dementia or neurocognitive disease be caused by HIV? So the answer to that is no, not typically. And so now there is, back in the time when AZD was used more frequently, it was actually often used in people who did have a form of hand, or AIDS dementia is actually a form of hand. It's just a more severe form. So there's different levels. So milder hand is for someone who just may have some forgetfulness, or may have a little bit, their thinking is somewhat a little bit slowed. So, and sometimes you can only tell that by doing some very detailed tests to test how quickly people are able to answer certain types of questions, that sort of thing. It may not even be something that a person recognizes their symptoms. When it gets to be more, moves along and progresses more, then people would start to maybe notice the symptoms, that they find themselves being more forgetful or having lots of problems finding words when they're talking, that sort of thing. And then moving on to more severe is AIDS dementia, where people ultimately stop remembering more common things, like you may forget your partner's name, or you may forget something like, your mother's name, or something along that line. Those are more severe and progressing on to more severe AIDS dementia. And so it typically has not been associated with the medications. The medications typically would make people better. So people that have more severe hand often get better on antiretroviral therapy. Maybe not all the way back to normal, but better than people that aren't on it. And certainly being on antiretroviral therapy appears to make it much less likely that a person would develop hand. So if your viral load is suppressed and you're on HIV medicines, the likelihood of developing hand is much, much less than if you didn't take HIV medication. And then the second question was asking about anemia. And so anemia can be associated with HIV disease itself. So if you have HIV disease that's not treated, so you're not on HIV medicines, anemia is pretty common. But once people start on medicines, then their anemia should get better, and they shouldn't continue to have anemia. Now, some HIV medications can be associated with anemia. Actually, AZT is probably the one that is most commonly associated with anemia. And so if someone who goes on AZT develops anemia, then their doctor should switch them to a different medication if AZT is the cause.
Okay. Thank you for answering that as well. And there were a couple more questions that we got in. One was, why is it more likely for an individual to be more likely to be drug resistant if exposed to HIV in the womb? That's the first question.
Okay, so I can answer that one. It's not. So one of the things is that if a person who is pregnant has HIV and has HIV that becomes resistant to HIV medication, so they take their medications inconsistently or erratically, and they develop a virus that's resistant, they can pass that virus on to a child if they were to be pregnant and deliver a child. If they're on antiretroviral therapy, as I mentioned, and their virus is suppressed, so this is important. If pregnant woman, HIV-infected woman, pregnant, on HIV medicines, the likelihood of transmitting to a child if they have an undetectable virus is less than 1%. So, but the issue of resistance, if you have someone who has HIV that's not controlled, and it may not be controlled because they've developed some resistance, again, from inconsistently taking medicine, they can pass that resistant virus on to a baby. But that doesn't make, so I want to be clear that it's not necessarily more likely that a person that has acquired HIV perinatally is more likely to be resistant, but it can happen, again, if the mother had virus that's resistant.
Okay. And the next and last question I think that we got in is when an individual is presenting with hand symptoms, how does that differ from symptoms of dementia or something comparable?
So I think we answered that question a little bit in that AIDS dementia actually is a part of the sort of hand syndrome. So hand sort of ranges all the way from some of those mild symptoms that I mentioned to all the way into AIDS dementia. And so, but some of the early symptoms of hand could be some of the things that I talked about, like increasing amounts of forgetfulness, or sometimes having a tremor, or maybe even just having difficulty with some types of movements, or having what we call a movement disorder, sort of similar, more severe version of a tremor. Those are some of the symptoms of, some of the earlier symptoms of hand. But like I said, not everyone who has even a mild version of hand even recognizes that they have symptoms.
Okay, so I think those are all the questions. There was a question, and I do think it's, you know, something that also kind of sets the stage a little bit for what we're going to be talking about, but I think it's important to bring up that we're talking about, you know, trying to have a seat at the table and having your voice. Someone said there's many long-term survivors who have been very active in HIV community through advocacy and board positions, but have found themselves no longer as active due to major changes in funding streams and no longer the sense of urgency around HIV that there was in the earlier days, and are now having too much time to reflect on what transpired over our lives and being HIV positive. This has created the acknowledgement of PTSD, but lack of mental health services is making it difficult to get support, especially those of us now on Medicare. So I'm not sure, you know, I think it's a lot to answer, and I don't know if anyone has the answer to that, but I just thought it would be, if anyone wants to chime in on thoughts around that. Get a little feedback. Okay. Well, I mean, just from an organizational standpoint, I think it's very true, and I think that's why, you know, even the term AIDS survivor syndrome is a fairly new term, and it's, you know, and I think it was really driven by long-term survivors that were kind of pulling together all this information through themselves and support groups, and you know, saying that this is something that we really need to look at. And I think there's a movement, and you know, one of the organizations that was on the slide, Let's Kick Ass, is really trying to you know, get more information and you know, drive a little bit more research towards you know, this population, because it's a growing population, as we all know. You know, the number of people aging with HIV and going to be over 50 is going to be a very large number in the coming years, and there's a lot that we don't know, even around women and menopause and hormones. I mean, there's, you know, there's some research, and but there's still a lot to be done. So does anyone else want to add before we close up the webinar? Maria and Tranisha and Dr. Smith, if you want to add kind of some closing thoughts.
Well, I'll just close by saying thank you to the Well Project for inviting me to be here. I was happy to be able to have that conversation, and this was really a great experience.
And this is Maria. I want to say thank you to everyone for participating, and I hope to see you all in the webinar part 2. Thank you to the Well Project, to the wonderful doctor, and to Tranisha for making this so much, trying to, I guess, we're all on this together, and I just hope to see you all in the next webinar. Thank you.
Yeah, this is Tranisha. Sorry, there's a lot of background noise. I just want to thank the Well Project for inviting me on board and for everyone participating. The conversation around long-term survivors is still new, and it's really, really important that we're having these conversations. So I'm just really glad to be part of the community, and thank you for the Well Project.
Great, and I want to thank each of our presenters so much for being here. And Dr. Smith, it was a pleasure working with you again after many years. Thanks for all your input as a provider, and again showing kind of what a model doctor should be. And to Mejia and Tranisha, I know sharing some of these experiences can even be difficult, and I just want to thank you for being so open and sharing, and helping others to understand that they're not alone, and to see that there are ways to kind of beat this, and and to not give up. And so I really appreciate everyone and all the participants, and I will just say that this is being recorded, and we will send out a notification when it's posted to our website along with the slides. If anyone, I know it seems like we had quite a bit of drop off from the registration, so if you know anyone that missed it, we'll be sending out that information soon, and we hope that everyone can join us on the next one. Mejia and Tranisha will also be part of the panel, and we have Dr. Teresa Mack, who has also been treating people living with HIV since the 90s, and with a specific focus on women as well, who's going to be our other speaker. So hope to see you on November 14th. And thank you again.
Thank you all. Bye.
All right. Goodbye, everybody.
Bye.